So turning to essential thrombocythemia and polycythemia vera, I think there are several unmet needs. Certainly we have effective medications to control counts, hydroxyurea, interferons, anagrelide to a certain degree for essential thrombocythemia, and phlebotomies for polycythemia vera. And there are additional agents that are used very infrequently, such as busulfan, but also carry a heavy price tag of progression to AML. So we definitely want to hold our punches there. But a lot of these drugs don't address symptom burden as well as as we'd like. So patients with ET and PV can be heavily symptomatic, and even if we can control their counts with, say, hydroxyurea, phlebotomies, or anagrelide, a lot of times their symptoms can persist because they're being driven largely by cytokines. Ruxolitinib is approved for polycythemia vera after hydroxyurea and certainly addresses that issue. We definitely see in both trials and our own clinical experiences that, for patients who are heavily symptomatic, say with itchy skin or night sweats, or even, struggling with some splenomegaly, can have quite a bit of benefit for ruxolitinib if hydroxyurea isn't improving their overall symptom burden. So I think that has begun to address those needs. Interferons have preliminary data showing some interesting effect on the disease at a more deeper level. We know that hydroxyurea, anagrelide, phlebotomies certainly don't clear out clone. It does not have a deeper effect on the disease, reducing allele burden or perhaps turning back the clock on these diseases, maybe even but we really need new therapies that can delay progression. Within respect to interferons, we know that a small proportion of patients on interferons will go into molecular remissions, which we all assume is a good thing, although there's no hard data to prove that that is truly delaying progression or turning back the clock on the disease. There was one retrospective analysis out of a single institution that did show patients treated with interferons versus hydroxyurea had a better myelofibrosis-free survival, but it's a single institution retrospective analysis done over many years, and obviously has a lot of methodologic flaws that are not overcomable, and really more prospective data is needed. So as we follow out studies like the PROUD PV study, hopefully we can follow those patients for a long time and start to get a readout of whether reducing allele burden can really translate into a better myelofibrosis or progression-free survival. But we are turning to new agents in the field. Of course, there's a very keen interest in regulating hepcidin in patients with polycythemia vera to get them off of transfusions and away from iron deficiency. But across the board, we're really looking for, again, new therapies that can deeply affect the disease on a clonal level, eliminate the clones, delay progression, and really root out the disease at the deepest levels.